This week on the Physio Foundations podcast, I'm talking to physiotherapist and osteopath Jaap Switters about the clinical management of male chronic pelvic pain. Welcome back to the Physio Foundations podcast for another week, the podcast about the knowledge and skills that provide the foundation of expert clinical practice. And just a reminder, this is a discussion aimed at health professionals and health professional students. So you should always seek the guidance of a qualified health professional with any questions you may have regarding your own health or a medical condition. So this week, I'm talking to physiotherapist and osteopath Jaap Switters about male pelvic health, specifically about chronic pelvic health and prostatitis, although that's a term we're about to discover is an old term, but we'll let Jaap explain that one. I'm really happy that we've got this topic on the podcast. We're moving, not that it's not important, but moving away from just talking about perhaps musculoskeletal and anatomical topics, for example, into more broad topics in physiotherapy. And Jaap's going to be a really interesting interview to have here. So Jaap owns a clinic in Vienna, Austria, and he has an undergraduate degree and a master's degree in physiotherapy, and he has a degree in osteopathy. So he's a physiotherapist and an osteopath, and he has a special interest in both musculoskeletal injuries and in male chronic pelvic health. So I'll just explain as well that Jaap is a good friend of mine and we did our masters together. So we're going to use this as an excellent excuse to catch up. So Jaap Switters, welcome to Physio Foundations.
Thank you, Luke. Thank you for inviting me. It's a big honor.
Oh, sure. Honor's mine. So it's good to catch up again. So let's explain how we know each other. So we studied in the University of South Australia. We did our masters together over there. So
2008, long time ago.
It is now. It's gone. Seems like yesterday. And what have you done since then? You've been working in clinics and tell everyone a bit about yourself.
So after finishing my master degrees at the USA, I moved back to Europe and I moved to Austria, Vienna, where I worked there and also in a clinic with mainly orthopedic problems or injuries. So we're working with a doctor as well, specialized in the knee. So saw many ACLs, many knee operation, but also conservative treatment as well. And during those years, the first couple of years, I tried to specialize in anterior knee pain. It was an interest of mine. And later on, after a couple of years, I started working one day a week as well at a rheumatologist. And that was quite interesting as well to see different kind of patients as well, different problems. And in 2017, I started my own clinic. And also since 2017, I started working together with two urologists. And in that time, also the interest came in male chronic pelvic pain or chronic prostatitis. And since the last 4 or 5 years, I'm also mainly working also with these patients, which is quite interesting as well, and also also a challenge for me as a therapist to find out what is the best treatment strategy or the intervention strategy.
So you've got diverse interests: anterior knee pain, musculoskeletal health, and your sports and Musk Masters that we did together. And so then was that just a bit of luck, or was that some planning that you worked with rheumatologists and when you set up your clinic? How did that come to be?
Sometimes it's just a little bit of...
Sorry, I said rheumatologist. I meant the two urologists that you worked with when you set up your clinic. Yeah.
So it's a little bit of coincidence. So in one way, it's just when you work for a couple of years in a certain area, it's always to see something else, to see sometimes different kind of patients with different complaints, and you try to treat them. Also a little bit to challenge yourself and see something new and get a little bit out of your comfort zone. And with the urologist, it was just, we had a mutual friend and he was looking for a therapist who was working in this area. So then we got into contact and then he referred the patients to me. And in the beginning, you also see a little bit of your direction you go. In the beginning, he was really mechanical. He really looked at, for example, the chronic male pelvic pain. What are the issues? What are the impairments around the hip, around the pelvic, the soft tissues? With the osteopathy was mainly as also the visceral manipulation of the bladder and so on. And at a certain time, he said, a certain group of patients you were successful with, the other people were so la, and so people didn't help at all. And then with also the master of the UniSA, you learned how to find your own evidence, or your evidence of the papers. So you start reading a little bit more, you start ordering books, so you're reading more and more. And then you're going a little bit away from just the mechanical part. You take a step back, and you have to look as well as perhaps there are some ideas or some misinformation which aggravate the factors as well. And then you were looking for for example, some podcasts or also some books which you could recommend to patients, whether you have the right information on it. And this is how you grew into it, and your knowledge got better and better. And then you're starting to structure your knowledge to also provide the right information to the patient, and also to provide the best treatment as possible for the patient.
So male pelvic health is an area that it's fair to say that there's probably not enough clinicians working in. You're working in an area that has a real demand for it, and there's a real burden of this problem for people. So what trouble does it cause for people? Let's talk specifics about this condition. So what is male chronic pelvic pain, prostatitis? What is it, and what problems does it cause people?
It's very different. So it could be really a burning sensation in the pelvic area. It could be also a numbness. It could be pain in the testicle area, in the groin area. It could have impact on the sexual function. It can have a impairment in the bladder function. And the bladder function that they have to go quite often to the toilet, or it doesn't come anything out of the toilet, or with the sexual function, it could be pain during an orgasm or after an orgasm. It could be pain with sitting. It could be a referred pain in the penis, the tip of the penis itself. And the challenge is because if they already have the courage to go to a urologist, they look, of course, okay, what could be the cause of the problem? And first of all, they look at the prostate. Is there an inflammation going on? Is the size of the prostate perhaps bigger, which caused the problem? Is perhaps there's a tumor going on? Is there something with the bladder? Is there a low urinary tract infection or something? So they have their list, which they strike off, and if they don't find any quite explanation for the problem, and when they have, they usually get antibiotics, or when they find something, they get antibiotics as well. That's usually the main treatment. But if their symptoms doesn't improve, then when you have a little bit of bad luck, some urologists, they don't know anything else, and then some patients are going to shop, and they go to the next urologist, and perhaps they get another antibiotics, they get the same examinations again, and at one certain point, they have examinations, perhaps it could be harmful for them as well, or completely useless for them. And that's a little bit of the gray area, because you have the structural problem, and then you have a little, perhaps, the functional problem with it. And that's a little bit of the area where I step in, or in the gray area, and you try to find them help. So it goes like, what could be other issues would have an influence, or why are these symptoms perhaps the main cause? Perhaps it was an inflammation. The inflammation is gone. Why are still the symptoms over there? And then you come a little bit in the chronic pain area, and perhaps a little bit of the central sensitization area. That the nervous system is too sensitive, and process the information a little bit wrong. And that's a little bit of the area where you're trying to help them. And the challenge is, as a therapist, because you're looking for information as well, perhaps you want to take a course as well, is that the main courses about pelvic health are for females, and the main courses for the pelvic area, the pelvic muscles, are also for females. And if they are any courses for males, it's mainly about a prostatectomy, when the prostate is removed after perhaps a cancer cells are found in it. But when you really have a male chronic pelvic pain, whereas you have a 19-year-old who has continuous pain all day, there is not really a course which you can take, and you have to find a little bit you have the right books or the right podcast. In the last 2-3 years, it's getting better, but it's still quite of a challenge. So, and it's also not known by many therapists, but also not known by many urologists, which makes it also quite frustrating for the patient itself.
I can imagine that'd be a really frustrating pathway to be on, especially when you said they're shopping between urologists and looking for treatments. And then the more that happens, the more the condition is going on, and they're not getting solution, not getting the education they need. I like it when you said that they need the courage to go to the urologist. I mean, that was a really interesting choice of word there, in that
it's definitely it's a courage. Because it's okay when you have low back pain or you have a knee pain, then, for example, you're meeting your friends, say, oh, my back hurts and my back aches, and what should I do? And then someone says, oh, I know a good therapist, or I take a massage, or go to that doctor. And this is an area when you say, well, I have so many pain in my testicles or anything, you don't really talk with anybody about it. And even if you're in a relationship with your partner, there could be quite a lot of shame of it as well. And then to take that step and to have an examine it. And for example, when you have testicle pain, now Google it, the first thing what you find is testicle cancer. And of course, the alarm bells goes off, and it creates perhaps more pain. Right. And when they have the courage to go to a urologist, and perhaps they say, and then it's checked and they say it's all fine, there's no cancer. But some people, the alarm system goes off and it's fine, and they go out and they don't have the pain anymore. But other people, they have the feeling, well, perhaps he didn't find it, or he didn't look at it carefully. So that's one part. But the other part is as well, when you look at the research which is done on male chronic pelvic pain, is perhaps the last 20 years. And when you look at what could be aggravating factors, for example, horse riding. When you look at the mankind, how long we have been horse riding. And so you probably would expect that that problem would be way longer than the last 20 years or perhaps 30 years. So it's not really an issue which has been discussed. It's not really an issue where there's a lot of information about it. And that's why it's and if you compare it with female pelvic health or female chronic pelvic pain, that's been much more research, and there's much more knowledge, and more more doctors know about it. But for the main male pelvic health or chronic pelvic pain, it's still a little black holes, a little bit quite negative, but it's still a really big gray area.
And it doesn't help that men can sometimes be less inclined to go to the doctor and check things out. I mean, I'm really at pains here to point out that this is a podcast for health professionals, and I did that little disclaimer at the beginning here. But I think we're on fairly safe ground here, saying that anybody listening to this, if you have any doubt whatsoever, and you could be a health professional or a patient, and you have any of these symptoms, if in doubt, get it checked out, and go and see your doctor. But of course, you may end up on a bit of a frustrating journey between people, but until you find the right person who can help you. But hopefully, by having podcast episode, you mentioned podcasts before, having a podcast episode like this on this topic, more and more discussions, we can normalize and make it a safe space to talk about this stuff for men around the world. So, if in doubt, get it checked out. If I talk to physio students, and I shouldn't say physio because you're a physio and an osteo, it could be a health professional of any sort. It's just that I specifically teach first year physio students, and we've just been through lumbar spine red flags and bowel and bladder questions. It was yesterday. We spent a lot of time on it. And that's what you talked about. So those screening questions for the bladder and the bowel. So you mentioned stopping and starting the flow of urine, fecal incontinence, sexual function, pain, and pain with sitting. So do you have any tips for students for, sometimes it can be a tricky area to talk about for the therapist as well. So having a bit of a script can sometimes help, and something that you practice saying and a way of saying it. Do you have any tips for asking these questions that are of more sensitive nature? Because you do have to ask them. You have to ask every patient who comes in with a lower back pain. You need to screen them for bowel and bladder and pelvic health. You can't just assume that they have back pain, leg pain, and the pelvis is fine. That's actually a part of the body that you need to screen for, right? So any tips for students for asking these questions routinely?
Yeah, so as you mentioned before, it is quite challenging. And what we mentioned before, if the patient has the courage to go to a urologist and he takes the next step and comes to me, they still have a hard time to talk about it. And meaning, so when I ask them, where does it hurt? And they say, down below it hurts. They go, where does it hurt? In the penis, in the testicles, in which area, in the groin area, and so on. And it was still, I had still the answers were not really satisfying. It was not really also for the patient quite uncomfortable. So in one way, it's when they come to me. So it's sometimes you have to adapt a little bit on the words they are using. So when they talk about not about the penis, but for example about the dick, then you try to use that word as well to stay on the same level, that you talk about the same things. And my solution in general was a little bit, I use questionnaires. So you have the National Health Chronic Prostatitis Questionnaire.
Okay, so it's just a validated patient-reported outcome or questionnaire that you can give to them and break the ice with that conversation. And they tick yes to something, and you say, okay, let's talk about this more.
Exactly. So then you have the 4 points where it could be painful. It could also, you have a little bit about the going to the toilet, but also a little bit about how much of the time you think of it. How is your quality of life at the moment? And I think that's a little bit quite important in this area, because it's really hard to get, I say, assessment and reassessment tools. That you say, okay, how much does it hurt, or how you're impaired? And because it's a hard time to talk about it, it's really hard to settle a baseline. And by making a little bit, they have to make a choice. They have to sign, okay, yes, it hurts, doesn't hurt, from 0 till 10, how much is it? And then you have, at the end, you have to score. I think it's a maximum I think it's a 49 or something, or 59. Then you look at how much they have, and then you can compare it with the next time. And that's a little bit in both ways as well, because if it's improving, then you can give them positive feedback. Look what you did the last couple of weeks or 2 weeks, and that improves. So please continue that. And even if it's get aggravating, then you ask the question, okay, what you did the last couple of days, or what could be? Could it be a stressful event? Did you move less, or couldn't do your exercises? So that's a little bit of an area what I got good with it. It's just the questionnaire. And then when something is really notable on the questionnaire, or when they want to talk about a certain topic or a certain question, then you just listen to them, and then you go a little bit deeper in it. But the difference for me, of course, is that they come from a urologist. And so they have that's I think a bit different than when they come from the orthopedics. From they have with the MRI scan of the lower back, and they come then to you, and then when you ask something about the pelvic area or that area, or sexual health, it could be a little bit too much confronting. In one way, with me, they expect it a little bit, but it's still hard to talk about it.
Right, because the expectations of what you're managing expectations is so important, and the expectations of what you think you're going to get out of a therapeutic consultation can determine so much of your buy-in and your approach to it, and as a patient. So that's a really interesting point. So what sort of conversations do you have to lead into some of these questions? Do you, for example, say, well, do you sort of explain first that this is the problem, and if I can help you, if I can ask you some of these questions, and some of them are going to make you feel a little bit uncomfortable. And then, of course, you're going to get consent to talk about these. And I always talk with the students about getting your overall consent for the appointment, generally to touch the patient, to expose the part as a general thing, and explaining what you're doing as a physiotherapist, don't assume. But also just that when you go to, it could be as simple as if you're going to be doing some palpation under the axilla, under the armpit, okay, near the breast, or in the groin, okay, extra level of consent. So there's an extra question there. So explaining exactly what you want to do and why, and giving the person an opportunity to say no is just so important. For so many reasons. So with these questions, it might be the same. Do you sort of talk to them and provide a bit of a lead in first before you ask the more sensitive questions?
Well, in the beginning, it's also says a couple of things. So one way, you do your subjective examination. When you have the feeling in certain area there's a lot of resistance, or you have the feeling they don't want to talk about it at that moment. Sometimes you need to build up a relationship. They need to have some confidence in you as well. And yes, mainly what I do in the beginning is so when we finish the subject examination, then you usually go in. So, okay, do you want to have is it okay when I talk to you about another explanation about your complaints? That it's not only mechanical, it's not only the prostate. It could be also your nervous system. It could be the central sensitization. So the example, which I always, I got it from a course as well. I learned it from somebody else, but it's a good example. The first question is, are you wearing any socks today? And then
Okay.
so usually they say yes. And it's like, how do you know? And say, I feel the socks. And it's like, okay, for 5 minutes ago, did you felt the socks as well? And it's like, no, not really. So I say, well, what happened then? It's like, oh, yeah, I noticed it. I focused my attention to it. And then you really try to do, okay, that's the way the nervous system works. And that's a little bit to go on. Then I start with my radio. So when you have the volume of your radio, you can put it up, you can really loud, or you can turn it down. And then the second question is always, okay, which organ has influence on the volume? And then usually they say it's the brain. Yeah, and say the brain that we can influence. We and then so that's a little bit of the basic introductions to it. And then we start with, okay, what other influence can I help you with by turning up or lowering down the volume? And that's in my first treatment is a little bit about certain movements, trying to get movement again in that area. So actually not really hands on. And then the second part, and then a little bit of the parts. Okay, what of your lifestyle? What kind of products do you eat? What kind of do you drink? How is your physical activity or the inactivity? And then also a little bit perhaps about the ideas, or what's the source of the information. I mean, everybody Googled it, but what did they Google? Which forum? What kind of information they got out? And then you ask them, okay, when you look at Dr. Google, how does it work? Does it put the volume up or does it volume down? And then when they say it goes up, it's okay, then try it as good as possible to avoid it, or try to read this or listen to this podcast, and that podcast can help you by turning down the music.
So going on
And
the
that's a little
internet
bit,
and discovering things that may or may not be true, and always getting the worst news first, that can really
definitely.
feed into the pain experience for people, particularly with this problem, given
Yeah.
its sensitive nature and perhaps you mentioned almost shame. I think you said before, for people having difficulties talking about and coming forward with these things. Once they come forward with it, is there a sense of relief? Have they broken the ice and they've got some answers? And are they moving forward then? Is it a different
It
experience
is.
for them?
It is. Also, the first step is that's always. Then you go a little bit about the change. So when they have to do some changes in their lifestyle, in the dietary, perhaps the sleep management, perhaps the stress management, and so on. So the first step is it's where they feel a line of relief or perhaps some hope from, oh, I can do some things about it. But then the challenge becomes, okay, when I come at home after work, I shouldn't lie on the sofa and watch Netflix. Perhaps I have to do some stretching exercises, or I have to do perhaps some trigger points, or perhaps do at that moment some breathing exercises instead of lying on the sofa and watch Netflix. Or when you say, well, I know alcohol, because like a glass of alcohol can ease off it a little bit, but I drink 2 or 3 glasses of alcohol, it could next day could aggravate it. But when it's football on telly and it's an important game, I always drink a beer with it. So I have to change my pattern with it. And that's
And
a little
giving
bit.
them that awareness of that they may not be aware of before. Yeah.
Exactly, and that's the biggest challenge, and that's usually from the first of the second treatment. You usually see a little bit, you see an improvement, and then the hard part comes at the perhaps the third treatment, because then it takes a longer period over time to make those changes, and especially when we talk about the noise and about our radio, those slow nerves also takes time before it settles down, and it's usually, and then also a flare up starts popping up, and then it's like, what are you going to do when a flare up is? And those are a little bit of other challenges, and then you have to, as a therapist, you have to really focus on the positive. So when you say you have a flare up, it usually means you have a period which was better, and then it gets a little bit worse, and then perhaps it gets better again. And that's a little bit where you have to focus on the periods. Okay, you have 2 3 days no complaints, then the complaints start again. Okay, now we have to focus not only 3 days, perhaps 5 days, and you try to make it a little bit bigger and bigger. And that's also a little bit of the challenge that they, yeah, because it's a long history, they get frustrated with it. It's hard, and that's a little bit of those life changings what they have to make. And yeah, every change is a factor of learning, and you're not everything you learn, it goes with some error in the beginning.
Mm. And so a big part of what you do is addressing psychosocial factors and lifestyle factors. But you mentioned
Yeah.
structure and function early on, but thinking about the person's lifestyle and their, and these contributing factors. And then you also mentioned behavior change and motivational interviewing earlier.
Yeah.
And so So in terms of behavior change, so what are some of your strategies that you use? So this is not something that we get a lot of training on. You know, we tend to have a biomedical model. Nowadays, there's much more of a biopsychosocial influence over the training of therapists, but still a lot of it you learn from being in the trenches and working with people, right?
It is.
So how do you go about, I mean, you've already touched on some of this, but perhaps the specific techniques you use for people to help them make those changes?
Well, so the behavioral change is you always start slow or small steps. So, for example, when you say when you're at home, don't take the lift, take the stairs. When you go by public transportation, get out sooner, one stop ahead of it, and you walk that area towards. Or when you go in the shower every day in the morning, you just start moving your pelvic area and do it 30 times in every direction. And you have those small parts already during the day integrated, but it's not much a big change, or it's easy to do, and it could be fun as well to do. And then it's a little bit, the next step is a little bit of a little bit of the motivational interviewing. Is, I think every therapist knows it, as a therapist or as a healthcare provider, is the solution. And then sometimes you think, oh, it's so easy. If you just do that, then you don't have the problem anymore. And then you think, so why is it not happening? Why are you not doing it? And that's a little bit it's when you start reading in it and perhaps taking some courses, it's like the motivation has to come from itself. And then you can ask questions like, if you don't change anything, what would be the benefit of it? What would be the benefit if it stays like this? And then not really focusing quite on the negative, man. So then it must be some benefit, or else perhaps you would change it. So it's easier to watch Netflix, for example, or it's not so hard. It's easy to do. It's easy, the road of less resistance. And then you ask them, okay, what would be the benefits of changing it? So less pain. I can perhaps see my friends more easier. I can do more sports. So I can do more that. And then you try to find out, okay, which had more weight in it? Is it more important for you to see the benefits of changing it, or is it the benefit of not changing it? And so you're trying a little bit of with also a little bit of the central processing activation as well, and that they hear it themselves and they work it out themselves. And I think the other thing for me is really important, that you have the background information, that a change sometimes can take up to 6 months. So a change is not something from the first to the second appointment, or from the second to the fifth appointment. It could take, so it has to grow a little bit, and they have to try it out a little bit, and then it grows and grows and grows. And at one point it's normal again. It doesn't feel like it's a big effort. And I think that's also an important information, that we're sometimes expecting too fast a change, and that's sometimes not realistic.
Managing those expectations.
Yeah.
That's a really nice summary of what motivational interviewing is. Sometimes I think it might be conflated, but with the assessment, so the patient interview, the information gathering exercise, and then patient education is often, it can be delivered sort of didactically, just delivered to someone. Oh. The white coat will be telling you what to do, and here's your education, and now you know. But what you're describing there is really empowering for the person, because you're getting them to think of entertain the idea and change from the top, from the brain down. What might be different? How could things be different for me? And getting that intrinsic motivation. It's a nice summary.
And it is, because it's usually, the problem is not the information. It's usually not the lack of information. When you see, because sometimes it is with chronic pelvic pain that they get the right information, but sometimes with other problems, by being perhaps overweight or physical inactivity, they know it's not good for them. They know they have to change something. So the information is already there. And when you focus with your patient education too much on you have to do it because of that or that and that, that's usually you create resistance, and usually they disagree and straight ahead of you and say, no, I'm not going to do it. Or they say, and they go out of it and they don't do it anyway. And that's a little bit, so the collaborative approach is important to see how can you motivate it. And that's for the patient important, but for you also as a therapist, especially for the long run, is when you have a couple of those patients during a day, it could be quite frustrating. And when you try to find a collaborative approach, then you know, okay, that's the part of the patient. I can help him, I can be his guide, but it's not my responsibility. I think that's also important as a therapist to know.
So yeah, and sometimes it's really helpful to hear other people talking about this, because if you're practicing on your own with a patient, and that's some deep reflection that you're doing there, and I'm sure other therapists and potentially students listening to this have come across that frustration, and there is a different approach. Tell me about. Let's talk about evidence. We'll do a segue to some of your research that you've done, but clinical guidelines. Is there anything for male chronic pelvic pain or health that we could refer people to? Any clinical guidelines, or we're at that stage yet?
No. So one point where the urologists are at that moment that they one way recognized of the male chronic pelvic pain. That's also that they know what's the definition of it, what the symptoms are, and so if you have for a longer period than 3 months, in the last 6 months, if you have these complaints, that will be fit in the male chronic pelvic pain. So that's a little bit of the first step, and then also the symptoms what they have. And then it's a little bit what they do is it's the UPOINT system. It's a little bit of the urinary tract. Is there anything wrong with? Is the psychologic anything wrong? Obstruction, infection, could be therapy, could be neural. That's the N. And they look a little bit at those spots as well. And that's a little bit quite general. It's not really worked out. I mean, it's good. It's a very, very good start. But a guideline, what we say, okay, that's the way to go for male chronic pelvic pain. No, so it's also for a little bit for the most therapists, also the experts we have worldwide. Is you have a little bit of the ingredients, what everybody put in. You know, it's important. But the guidelines until now, no, not that I know of.
Yeah, and the same in women's health, and with it's a really rapidly developing area, and there's a lot of groups. There's some leaders in the world who are doing a lot of work there, and I guess it's a watch this space thing in terms of an overarching guidelines. But what we'll do is we'll put that diagnosis summary that you just had there in the show notes for people, so they can look that up. And yeah, and let's talk about evidence-based practice in general then, because it's just a bit of a double meaning with physio foundations. It's foundational knowledge and skills, but I'm always trying to look at the foundational pathway. If I've got an expert, someone who's been doing this for 20 years, and there's some students or new grads listening, I really want them to see, where you can go and some of the stuff that you can do as a clinician to build yourself up. So we know already what you've done in terms of your qualifications. You've done undergrad degrees and masters, and lots of broad clinical practice. So in the masters you did. We did together, the University of South Australia. So you developed some evidence-based practice skills in that course. So that was your master's by coursework that you did. And then you've gone on to publish some papers, which is pretty cool. Congratulations. Yeah. Tell us a bit about those, the case studies that you've published.
So the first one, the case study was about, in general, it's in Europe, the visual manipulation. So as a part of the treatment, or the visual mobilization of the treatment, is quite popular. So you have many courses. It's a part of the osteopathy philosophy, and also the treatment strategy as well. And you have also many therapists who are physiotherapists who are doing these courses as well. And the thing is, what I was surprised about is that you have a lot of people doing it. There is some research coming. It's a little bit off. That was the first publication we did together as a systematic review of the for the low back pain. Does visual manipulation benefit people with low back pain? And there is some evidence for it, some small evidence that it could help a little bit. And the idea behind it is that the interesting part is one way you're finding the articles, but I think what I was quite interesting about is the introduction. Is a little bit to see if is what we've learned in the education about it, about the referred pain, about the I say the innovation of for example, of the bladder in combination with the thoracolumbar spine, thoracolumbar spine. So that could be so the innovation towards it could give an overload. It could be some tissue changes instead of myotome, dermatome changes, and so on. And you find out that when you look at it, there's also not much information or not really much research done about it. So the main group who did it are as a group of doctors, but they mainly looked at, for example, diseases or, for example, heart attacks. When somebody have a heart attack, they have referred pain to the left shoulder or to the jaw or something. Or when you have a rupture of the spleen, they could have left shoulder pain without any mechanical restrictions or impairments with it. And the idea of visual manipulation is that people without a rupture of the spleen could also have a referred pain in the shoulder, or the right shoulder could be the liver. And when you mobilize it, you can also increase or decrease the sensitivity in the shoulder. And that was my second paper, was the case study of a patient of mine who had an increased spleen. Actually, it was quite big, 14 centimeters long. And it was a size of the spleen. And she came in with not even shoulder pain. She came with thoracic spine pain, and that was quite interesting to see. And as you went to the GP, and of course you have to take into account that the GPs don't have much time. They have to look at it quickly. They have to have 5 minutes, and she only got some antidepressive medications. And then she went over to me, and then one way you looked at the back, you also looked at the abdominal area, and then you found around the left side a hard structure. The diaphragma was completely tense. Also the hard structure around the stomach area in that way. And then I had the feeling that something is not right. And then I referred her back. Then she had got an X-ray made of it, and so you also see in the paper. Then you see really a big spleen, calcification of the spleen, and that was actually for me quite impressive. Now, but it was surprisingly that something that big could stay for such a long period over time. And she had no history of an injury or accident or trauma in that way. And I think that way it's always helpful when such a case study to bring it out. It has, of course, many for the internal validity, many flaws, but for the external validity to bring it in the praxis, it could be really helpful that many osteopaths or physiotherapists who are working with it always have in mind, okay, sometimes we can find something that perhaps is missed by a GP, which it's quite normal. It's nothing bad in that way, but they will always have to keep in mind there could be something else as well. And then at the right time, refer them, and that they don't get unnecessary treatment or even harmful treatment, which could aggravate it or could be except also life-threatening.
It's a really important story there about differential diagnosis. And the key thing you said there at the end was if it's not improving, it's not responding to treatment, or it's not fitting a pattern. And of course, you've got all your red flag questions that you ask, and there's pressures on time and everything. But if you only had 2 minutes, that's where you start with those differential diagnoses and those red flag questions. So it started off with thoracic pain, and so this person can very easily spend quite a long time having treatment for their thoracic spine. They may or may not have improvement, which might correlate with symptoms. So I guess the point is this can easily be missed if we're not considering first of all, the red flag screening, and also looking at the person more holistically, looking at not just their back, but think about their organs as well.
And sometimes it could be, with her, some things were really mechanical. So when she was standing up for a long period of time, she got the pain increased.
That's then tricky,
when she was lying on the right side, the pain increased. She felt nausea as well. So at one point, you think, well, it's quite mechanical as well. So it doesn't really sound in that way as a classical red flag. But in my experience, what I had with red flags, usually it was, I think always it's a little bit of the gut feelings. It is when the patient comes in and tells their stories, you have your classical red flag questions, but usually there's some gut feelings, like something is not right here, something is not, something is missing, something is not. And I always, when I have that feeling, I just say, well, just perhaps do those examinations, go back to the doctor and just check it off a little bit more. And when I have that information, then I can I can do a safe treatment. But I think the gut feeling is not really evidence based, but I think it's a really important factor.
Well, it's not just the gut feeling. It's not just something you can't define. It's really, that's coming from the history. As you said, this person wasn't responding to treatment. A mixture of inflammatory, mechanical sort of signs, and there was some that really looked mechanical. And there always can be things that are misleading and tricky. But it wasn't responding to treatment in the usual way. So it sort of comes from the history rather than screening red flag questions. But
as well.
All right. Well, look, this is really interesting and really valuable stuff. I feel like inviting you back for another one, and we can perhaps we can go through chronic prostatitis. We can go through but a little bit more of the pathophysiology there as well. And there's so much more we can discuss. Let's finish up there. But there's a question I actually wanted to ask you that's not related to male chronic pelvic health. So big respect for you for doing this podcast. You speak 3 languages.
Yep.
Is that right? So what's your preferred language?
Well, it means I got some flaws in all 3 languages. I speak Dutch. That's what was my first language. Then I speak English, and then I speak. So at work in Vienna, I mainly speak German, and sometimes you have some patients as well as where you speak English with. So those 3 languages I speak.
I want to shout out to you and all the students I work with who manage all this terminology and patient communication and all these really complex, psychosocial issues, for example, and all the terminology, in different languages, and you're switching between patients in the clinic. That's pretty impressive. So it's something that you don't get as much in Australia. You get people who speak multiple languages, but it's common in Europe to actually to know multiple languages, isn't it? It's just sort of everyone has to speak a bit of English and Dutch and
English.
German.
So I think everybody speaks English as a second language. So if you're not a native English speaker, but the rest is, English is one of them, and I speak 3, but many speak 4 or 5 languages as well. So the challenge sometimes is, especially when when you're talking with patients, is to find the right words, and also that so the translation in your own mind is sometimes not really quite correct. And that's also, and that could be sometimes a little bit of miscommunication, could be of that the information is not coming through where you try to do. And that's always, sometimes a challenge as well. That could be an advantage, sometimes could be a challenge also.
You've done a great job with it. There's also non-verbal communication as well, and personality and connecting with people in other ways. But that's it's a challenge for the students as well who are doing this in another language. So big respect to you. So I feel like we're at the end. So listeners, once again, if you found this interesting, do all the things we want you to do. So like and share and subscribe and all of that. Otherwise, these episodes tend to not travel very far. It's all very much by word of mouth and referral. So if you found particularly this episode really interesting and relevant to your practice, and there's someone else who will find it useful, please just email them the link or share it online on social media. You can tag in Susanna and I at Periton Physio, and you can find all the links to the podcast players on our website, which is periton.physio. And final thoughts, Jaap. Any final thoughts? We've covered everything.
I think, So I think when it's for students and also for I think it's always good to stay open-minded and always be open for new information, and also I think critical is always good, but negative is the wrong way. I think that's always an important message, that you always stay open for new information. Especially when we finished our course in 2008. And if you look at that 14 years, what changed already from knowledge, and also how the interventions changed. And and I think as soon as you start we always did it like this, so why would we change then?
Yeah.
I think I think when you say those words, it should be a wake-up call.
that might be the beginning of the end. So keeping an open mind is a really good way to finish it, and work hard and get diverse experience. So we've got so much more to talk about. Let's do this again. But for now, thanks very much, Jaap, for a really interesting conversation. I hope that was helpful for everyone listening. So until next time, this is Jaap and Luke wishing you all the very best with your studying, professional development and lifelong learning.